Hi, good. How are you?
Hey, good afternoon. Pleasure to introduce Dr. Anand Nadkarni, giving us our lecture on atrial fibrillation today for grand rounds. Dr. Nadkarni comes to us from Mumbai, India, where he did his medical school. He then moved to Rochester, New York, another very cold location for study, then to South Dakota for his cardiology fellowship, with a third-year fellow. In July, he will be moving to Kansas, the University of Kansas Medical Center, to do an EP fellowship. Well, besides work and scholarly work, he also is a person. He likes to bicycle, play soccer, goalie, and fullback, and also is a very good dancer, which is a geriatrician. I'm very pleased to hear because you have aerobics, you have balance, and you have socialization. So, you should live at your practice. So, without further ado, Dr. Nadkarni.
Dr. Raj, everyone can hear me clearly. So I'm going to be talking about atrial fibrillation. I know it's a pretty broad disease. I'm going to keep it short and simple, but if we have some time afterwards, if you guys have any questions regarding things that I've not covered. So why are we talking about AFib and why am I talking so much about AFib is because it's the most common arrhythmias that you would see. It has got a prevalence of about 3 to 6 million, and it's estimated to go up to 12.1 million in the United States by 2030. So you're going to have a lot of patients with AFib. AFib increases with age, hypertension, heart failure. So these are the things that are going to get worse as we have our population aging, and you're going to have more elderly patients. So that's something that you rely on. Thing is, hypertension is the most common factor that contributes to fibrillation. Interesting thing is about 50% of patients who have heart failure with NYHA class 4 have AFib. So it's a pretty high percentage. And the other thing is about 34% of AFib patients have heart failure. So that's something that will be a common theme that you'll see among patients with AFib is they have some kind of heart failure, some kind of cardiomyopathy. We'll talk more about it, how we go about treating both these conditions. So this is just a fancy way of defining atrial fibrillation. It's an irregular supraventricular tachyarrhythmia, atrial activation with consequent deterioration of mechanical function. Best way to explain something is this picture. On your left side, you have normal sinus rhythm, and on your right side, you have AFib. You can observe in normal sinus rhythm, there is smooth conduction to the left atrium through the AV node to the ventricles, while in AFib, you have these small areas of fibrillation by that bombard against each other and cause AFib. So before I go into the pathophysiology of AFib, how do we come across this disease in patients? Most of the time, you will have patients who are symptomatic. If you have a patient who's asymptomatic, examination, you hear regular. So could be any one of these things. Yeah. So this is something that you need to keep in mind. It could be, multifocal atrial tachycardia, atrial flutter with variable AV block, sinus arrhythmia, sinus rhythm with PAC. So whenever you're examining patients, you could have these irregular rhythms. So you have to keep this in mind as differential diagnosis if you're suspecting AFib. And once you suspect that, you need to get an EKG to document what exactly the rhythm is. So this is important because that will help you decide whether a patient needs anticoagulation or not. So it's important that you figure out whether the patient is in AFib, flutter, or if they are in multifocal atrial tachycardia where you don't need anticoagulation. So pathophysiology. So the way one looks at AFib is you have triggers and a substrate. So you have some kind of trigger, and you already have a diseased left atrium that perpetuates this arrhythmia. So trigger could be any kind of premature atrial beat. Most of the time, this atrial beat comes from the pulmonic veins, and substrate is when your left atrium is fibrosed or has some kind of cardiomyopathy or some kind of dilatation that perpetuates this AFib. So what does this fibrosis do? If you think about in terms of electrophysiology, it decreases the atrial effective refractory period. So now we would have to think about physiology out here is if your refractory period is high, that means you would have lesser chances of getting depolarized. But if it's lower, then any impulse that comes to these cells, it'll get depolarized. The other thing is what happens with fibrosis, it disrupts electrical connection. So when I look back out here, you have in your sinus, normal sinus rhythm, you have smooth conduction from right atrium to left atrium because of these electrical connections. While in AFib, these electrical connections are, not working well, or they're blocked because it creates then these micro reentry circuits. So these electrical interconnection that not working cause there's something called as conduction heterogeneity. So that what it means is there's certain places in the left atrium that doesn't conduct well, certain places in the right atrium that doesn't conduct well. So that creates these micro reentry circuits, and that collides with each other and causes AFib. This is kind of important to understand why we do ablation, but we can talk further about it later in the presentation. So why do we have this atrial fibrosis? What contributes to it? Now, if you see the topmost risk factors that you see, hypertension, CAD, obesity, sleep disorder, breathing, these are all the risk factors that contribute if most of us know about it. But what they do is somehow or the other cause some kind of systemic inflammation. They cause some kind of atrial fibrosis through different mechanisms, whether it's hypoxia or whether it's RAS system activation, that is your renin-angiotensin-aldosterone system, or is it through autonomic dysfunction? Some kind of they cause this atrial fibrosis and some kind of systemic inflammation that creates the substrate for AFib. And in some cases, it can even cause the triggers that includes PACs, which again, you have the triggers and the substrate cause you to have AFib. So the reason why I put this up here is for us to understand why it is important to have risk factor management also in AFib, because that can, perpetuate AFib if it's not well. This is just a slide to show how autonomic system affects AFib. We often think of adrenergic system, increasing, the increasing automaticity and increasing the risk of atrial fibrillation. But even your parasympathetic system can also cause you to go into AFib. So that's something that we have to keep in mind. And AFib is one of those diseases that once you have it, there is a higher chance of you having it again. So AFib begets AFib, and it's important to understand that all the risk factors that I showed before contributes to some kind of autonomic dysfunction, and that's how this cycle perpetuates, and hence it's important to control these risk factors and manage them. So important terms. So this is technically classification of atrial fibrillation, but they have changed some guidelines, but we'll talk about it later in this presentation. But important to define what is paroxysmal AFib. So paroxysmal AFib is any AFib that terminates within 7 days. It doesn't have to be it can be with intervention, which includes cardioversion, or it could be just with medication. It doesn't matter. So it's an AFib that doesn't last more than 7 days. If it lasts more than 7 days, it's called persistent atrial fibrillation. If that AFib lasts a year, then it's called long-standing persistent atrial fibrillation. And permanent atrial fibrillation is more of a, it's not a medical definition, it's more of a definition between patient and a clinician where they say, well, they are not going to do any rhythm control to sinus rhythm. It's more of a decision that is made between the patient and the clinician. These are some obsolete definitions. Chronic AFib, it's a historical term. We often see it in our charts when we write down chronic AFib, but it doesn't give you an idea of what exactly it means. It could be paroxysmal, it could be persistent. Someone could have AFib 7 years ago, but it's just paroxysmal. Someone could have AFib that is persistent, it could be long-standing persistent. It doesn't help you out in defining what exactly is going on. Valvular and non-valvular AFib is kind of more related to your stroke risk. It's not related to whether you're going to do rate control or rhythm control, but they are more line and defined for stroke risk. In terms of what is lone AFib is something that is obsolete anymore. It's obsolete. We don't used to define patients in didn't have any structural heart disease, but it doesn't help with the management. So that's means great guidelines. So these are the other terms, and I know I've mentioned valvular AFib. Acute AFib is when patient is symptomatic, and newly diagnosed AFib is something that is frowned upon. You have a patient that comes in with sepsis, you put them on tele, and you find them on AFib. So that is newly diagnosed AFib. You don't know how long it will. Valvular AFib, as I mentioned before, it's based on your stroke risk and how do you treat them with anticoagulation. So when I say valvular AFib, it is patients who have moderate to severe mitral stenosis or mechanical prosthetic heart valve. The reason why there is initiation is based on anticoagulation, which I'll talk about it in the treatment part of it. So what does AFib get? So once you're in AFib, it creates a nidus for thrombus formation in the left atrial appendage, which later can cause you to have embolic strokes or event. Can cause electrical issues, fast heart rates, can cause decreased ventricular filling, which decreases diastolic, because most of your coronary occurs during diastole. It can lead to ischemia if you have diastolic. If you have rhythm irregularity, it can affect your cardiac output, which can lead to heart failure. As I mentioned before, AFib and heart failure go hand in hand. Mechanical issue, it can cause loss of atrial kick. In patients who have heart failure, it contributes about 40% of your cardiac output. Imagine losing 40% of your cardiac output. So these are the consequences of atrial fibrillation that one needs to keep in mind. So treatment, this is probably the most simplified slide I can make. It's more than this if you think about treatment, but this just gives you an overview. The one thing that you think about is anticoagulation to decrease the stroke risk. It could be with novel oral agents, or it could be with warfarin. Rate control, you have beta blockers, calcium channel blockers, and digoxin. Rhythm control, you can cardio with them. You can have antiarrhythmics of class 1A, 1C3, or you can think about catheter ablation. Other treatments, when rate control doesn't work for them, you can think about AV node ablation, pacemaker implantation, and left atrial appendage closure devices for patients who cannot tolerate anticoagulation. Usually AFib can occur in isolation, or it can be triggered by other clinical conditions like sepsis, anemia, COPD, heart failure, MIP. So one has to look for these secondary causes and treat them. Risk factor management, that is the cornerstone of AFib before it gets worse. So that's something we have to keep in mind. So I know everyone knows about CHADVASC. It's something that you can find at Medical, but I wanted to discuss further what does it entail. Once you get the score, based on the score, you try to figure out what is the stroke risk % per year. And we often say any CHADVASC score more than 2, we think about anticoagulation. So if you see CHADWAS score of 2 puts you at a risk of 2.2% per year of stroke. That's the cutoff that we usually use for anticoagulation or AFib. I could talk a lot about each of these components, but the most important thing out here to remember is each of these components, even if the score is given 1 and 2, they have a different weightage to it. For example, hypertension. Yes, everyone has hypertension in most of these patients. The question is it well controlled or not? We don't know about that. So those are the things that would tip you over. There is a difference between someone who has well controlled diabetes, someone whose EF is normal. So those are the things that doesn't cover with the CHADWAS, but that's something you can think about it while talking to the patient while discussing anticoagulation. The other important thing is you'll see that in different guidelines about females being given a score of 1. That is just because in general, females had a higher risk of stroke. That is only in patients who are older than 65. So I look at females as a risk factor modifier rather than a risk factor as such. So if someone has, for example, hypertension and they're female, they are at a higher risk than someone who is male and just has hypertension. So they have to have some kind of risk factors along with just being. This is from the latest guidelines for AFib and anticoagulation. As I mentioned before, CHADWAS more than 2 in men, and here they made more than 3 in women. That is to incorporate the extra point that they get as women. You need to start them on anticoagulation. The preferred anticoagulation is DOAC because over warfarin, it is known to reduce the risk of mortality, stroke, systemic embolism, and even intracranial hemorrhage. So whenever you're thinking about anticoagulation, the first thing you have to think about is DOAC or warfarin. If the patients don't have insurance or issues with financial issues, then you can think about warfarin. But preferably, you have to start with DOAC. That is class 1 recommendation. There is this gray area where what if your CHADWAS score is, for example, 1? It's not 2, it's just 1. They don't have an indication, a class 1 indication for anticoagulation, but it's reasonable to consider anticoagulation in those patients where you can think about other risk factors, which we'll talk about in the next slide, to help decipher patients who would benefit from anticoagulation and who will not benefit. In patients who are low risk or who have a CHADWAS of 0, there was initially an indication for aspirin, but that is no longer the case. You don't have to use aspirin in these patients. There is no benefit in preventing stroke in these patients, and if at all, there is a harm of increased bleeding in these patients. So apart from the CHADWAS, there are other risk factors that you can look into, that you can talk to your patients about when starting anticoagulation, if they have a higher burden of AFib or if they had longer duration. So there's a higher risk of stroke in patients who have persistent or permanent AFib than someone who has paroxysmal. Obesity, hypertrophic cardiomyopathy. As I mentioned before, hypertension, we often see it, but do we know whether it's well controlled or poorly controlled? So if someone has poorly controlled hypertension, they're at a higher risk of stroke. Kidney disease, that's a big one because that's not incorporated in your CHADWAS. So that's something that you have to keep in mind. And if the patient already has an echo, you can look at the left atrial volume and decide if the left atrial is dilated, that's something that you need to talk to the patient that they are at a higher risk of stroke. So we talked about CHADWAS as a score to be used for anticoagulation. Now I'll be talking about HASPLET, that is a score to see what is the bleeding risk. Now, there have been different scores to figure out what is a patient's bleeding risk, but none of them have been approved. But these can be used to see if they're at a higher bleeding risk, what is something that we can do to prevent them. Because if you look at the components of HASPLET score, some of the components are also there in the CHADWAS. So if you think about it, if someone has a higher CHA2DS, you're going to have higher Hasblet score. So that means they're at a higher risk of stroke, but even at a higher risk of bleeding. So what do you do in those situations? So first of all, any Hasblet score more than 3 is high risk. And this is not for us to say, well, because your Hasblet score is high, we won't start you on anticoagulation. It's more about for us to say, well, okay, your Hasblet score is high. What can we do? Are you on NSAIDs that can, predispose you for bleeding? Do you need to be on NSAIDs? Alcohol intake. What is your blood pressure? Is there something we can do about kidney functions? Can something about do with your liver function? It's more of a reminder for us to decrease the patient's bleeding risk and try to start them on anticoagulation, because patients who are at higher CHA2DS score and have higher Hasblet score, they actually have a net benefit with anticoagulation than without anticoagulation. So that's something that you have to talk about it if you have someone with Hasblet. As I mentioned before, if you don't have any contraindication, if they have non-valvular AFib, then you have to think about NOACs. If they have moderate to severe mitral stenosis, or if they have a mechanical valve, you have to give them warfarin. You don't need to use CHA2DS for them, because these patients are at baseline at a higher risk for stroke than non-valvular patients. Same thing goes with hypertrophic cardiomyopathy. You don't need to use CHA2DS. You can use NOAC or warfarin in those patients. And if you have cardioverted someone post-cardioversion for 4 weeks, you have to decline respective of CHA2DS. And after 4 weeks, you can decide whether they need to continue anticoagulation based on their CHA2DS. So if someone is not able to tolerate blood thinners and you have done everything in terms of decreasing the bleeding risk, and still they are at an elevated risk or have had bleeding episodes, then we have another option which we call left atrial appendage closure device. And the theory behind that is your left atrial appendage, about 90% of the left atrial thrombi occurs in your left atrial appendage. So if we were to close it, then you are decreasing about 90% of left atrial thrombi. And this was studied in these 2 trials, PROTECT Atrial Fib and PREVAIL, where they compared it with warfarin, and they found that there were more embolic strokes, which makes sense because you're not anticoagulating them, but less hemorrhagic strokes. So the overall stroke risk was similar. So it was kind of non-inferior to warfarin. And this is primarily indicated in which you have increased long-term bleeding risk, and not with someone who has complete contraindication to anticoagulation. The reason is because now this is specifically only for Watchman device, which is one of the left atrial appendage closure devices. You have to use anticoagulation or antiplatelet agents for at least 6 months. And this is usually used to help endothelialize the device well into the left atrial appendage. There are other devices that are there in the market that doesn't require this, but they are not as good in preventing strokes as Watchman device so far. So a little bit about rate control. You have a patient, you have diagnosed them with atrial fibrillation. You think about rate controlling them right now. If you have someone who is normotensive, rate controlling, if you want to rate control them, you think about beta blockers and calcium channel blockers. Importantly, you have to see whether they are in heart failure or not. Beta blockers are used in systolic heart failure. As long as they're compensated, you can use beta blockers. You can use even beta blockers in adrenergic mediated atrial fibrillation in someone who has, for example, PE, sepsis, or any kind of illness. You can think about beta blockers if they are non-hypertensive. Avoid using calcium channel blockers in systolic heart failure because of the negative inotropic effect. They tend to cause more hypotension than beta blockers, but based on some non-randomized studies, it has shown that it improves symptoms and increases exercise capacity more than beta blockers for same rate reduction. Digoxin can be used in someone who has decompensated heart failure, systolic heart failure, but they work more effectively if used in combination with beta blockers and calcium channel blockers. The reason why we use it in chemotherapy for decompensated heart failure is because you don't have that many options in treatment for rate control specifically. So you put them on medications. So what are we titrating them off? And it kind of depends on what the patient is what symptoms the patient is having. If they are symptomatic, you want to have them, aggressively rate control. But if they are asymptomatic from the AFib, if they are not in heart failure, then you can think about more lenient strategy based on the RACE 2 trial. As I mentioned before, you can start either calcium channel blocker or a beta blocker. If still rate is not controlled, then you can use a combination. If that is still not there, then you can add digoxin to it. Rate control in heart failure is kind of complicated. It depends on whether the patient is decompensated. If the patient is decompensated, you don't want them to have their heart rate decrease too much, because heart rate contributes to your cardiac output also. So you have to think about how decompensated they are they in cardiogenic shock? So those kind of things you have to keep in mind. Most of the time, about 80% of the people able to achieve rate control with these medications. So they are pretty effective. In those 20%, if you're not able to rate control them, you need to reevaluate whether you want to try rhythm control, and if that can be sustained. If you say that the patient has some kind of lung disease, it's an elderly gentleman, cannot tolerate amiodarone, and you don't expect them to maintain sinus rhythm, then you can think about AV node ablation and a pacemaker placement. Permanent pacemakers can be used in something called as tachybrady syndrome, which means that if you're an AFib, you give them rate controlling agents, and for some reason, there are certain points of time they get brady when they have symptoms, and that limits your ability to titrate rate controlling agents. You can, put them on a pacemaker and titrate them for their AFib. Sometimes you can have issues with hypotension, where you cannot titrate these medications and the patient is still in AFib with RBR. Think about AV node ablation and pacemaker placement. The older trials, AFFIRM and RACE, had shown that rhythm control had caused higher rate of hospitalization for recurrent AFib and drug-related brady and tachyarrhythmias. And that's the reason why we were initially erring towards the side of rate control. But on further review, they figured out that presence of sinus rhythm is associated with improved quality of life. Now, this is irrespective of whether someone was on rate control or whether this patient was on rhythm control. And that is one of the bases why we have to think about rhythm control in patients, is because based on these trials, first one I'll talk about is FNET trial, where you find someone in AFib, and it didn't matter whether they're symptomatic or asymptomatic or whether they're paroxysmal or persistent. As long as it was diagnosed within a year, you do rhythm strategy, improve cardiovascular mortality, outcomes, and stroke compared to rate control. This was based on a stepwise strategy where you first started antiarrhythmics, and if that still didn't work, you moved on to ablation. Specifically to heart failure with reduced ejection fraction, 2 trials were done, Castle AF and Cabana. Rhythm control with catheter ablation had decreased both mortality and heart failure hospitalization. These 2 trials. Important caveat, most of these patients were younger, and usually they had their respirant needed. Now, when do you say, well, rhythm control is not going to work for these patients, is when they have severe left atrial enlargement. which is pretty obvious. As I said before, if you have already a lot of atrial fibrosis, atrial myopathy, you have a lot of atrial, you have a lot of substrate for this patient to go into AFib and be in AFib and not come out of it and maintain sinus rhythm. So there's no point in for rhythm control in these patients. AFib for more than 1 year, as I mentioned before, if once a patient is in AFib for a long time, it causes a lot of anatomic and electrophysiological changes that makes them, be in AFib for a longer time. If they have any other comorbidities, if you have tried cardioverting them and go back into AFib, then these patients are not good for rhythm control. You have to think about rate control in those patients, and especially someone with older age. So management of acute AFib, if someone comes in the ER, obviously first you're going to think about what is their blood pressure, what is their heart rate, what are their symptoms. If you figure out that they're hemodynamically unstable, you think there are signs of shock, they have chest pain, they have shortness of breath because of the pulmonary edema, they are altered. You have to first think of it. Is this the AFib contributing their hemodynamic instability? And if the heart rate is more than 150, possibly it is, but if it's less than 150, it's very unlikely that it's causing hemodynamic instability. The caveat in patients who have systolic heart failure, cutoff is about 130 beats per minute. So if someone has heart rate more than 150, if they have normal ejection fraction, and if they have more than 120 beats per minute in someone with HFrEF, think about cardioversion, as long as you think that the AFib is contributing to their hemodynamic instability. If someone has decompensated heart failure and borderline blood pressure where you cannot use beta blockers or calcium channel blockers, then you have to think about amiodarone and digoxin. Whatever strategy you use, whether it's amiodarone or beta blockers or calcium channel blockers, most of the time, in 60% of the cases, AFib resolves, and by 48 hours, it's about 70% of the cases. The important thing is to continue treating the precipitating causes. If there is no resolution, then you have to think about what is the long-term strategy. Is this patient having a lot of comorbidities? Then you think about rhythm control. If not, then you can think about rhythm control in those patients. Important to see what the echo shows, what's the EF, do they have any diastolic dysfunction, what are the valves doing, what is the left atrial size also. If you are going for rhythm strategy, then you start antiarrhythmics, cardiovert them, and then continue the same and give them anticoagulation. Before, if you don't suspect that they will maintain sinus rhythm after cardioversion, then you have to think about rate control strategy. So I mentioned about atrial fibrillation and heart failure. They go hand in hand. AFib can cause tachy-induced cardiomyopathy. AFib can cause heart failure exacerbation in someone who already has cardiomyopathy. And sometimes AFib can be caused because they are in heart failure. So, they go hand in hand most of the time. And what is the rate at which you are comfortable in terms of someone who's in AFib is between 100 and 110. It's a very narrow window. You don't want their heart rate to be too low. You don't want their heart rate to be too high, because at that point you have increased oxygen demand and energy expenditure. And if you have systolic heart failure and your heart rate is more than 130 beats per minute, there is high chance of hemodynamic compromise, and you need to cardiovert them to help them with their hemodynamic stability. That being said, if someone you find is in heart failure exacerbation, diuresis should be your first thing rather than rhythm and rate control if they are decompensated, because even if you cardiovert them, there is low chance they're going to benefit from that cardioversion, because firstly, post-cardioversion, there is atrial stunning, so you won't get that atrial kick. And even if you have that atrial kick, it is against increased LV diastolic pressure, which prevents the atrial kick contributing to cardiac output. So you would be actually harming the patient if you cardiovert them without diuresis. So it's important to first diuresis them and see what their heart rate does. Most of the time when you diurese them, their heart rate comes down. So you don't need to actually cardiovert them immediately. Importantly, if you have someone who has ongoing sepsis, MI, don't try to cardiovert them because they're just going to go back into AFib because you haven't treated the precipitant condition. So it's important to avoid it and treat the precipitant cause. So a little bit about the updated guidelines on AFib that were released in December 2023. I'm just going to give you a brief summary of it. These were the main things that they talked about. We often talked about AFib in those 5 stages, but now that has been scrapped. We are talking AFib more in terms of a continuum, in the sense very similar to what we have for heart failure, where we have stage A, B, C, D. Atrial fibrillation will also have stages from 1 to 4. I'll talk about that in the next slide. The important thing out here is atrial fibrillation. The guidelines talk about early rhythm control. So if someone has low AFib, low EF, and they have persistent AFib, try rhythm control as your primary strategy to see if you can improve the LV function and prevent them from progressing to persistent AFib. In certain patients who are younger with minimal comorbidities and they're symptomatic from the AFib, it's preferable to go with rhythm control. And if you're going for rhythm control, catheter ablation is first line as per the guidelines right now. So the main thing is to try to prevent these younger folks to going into a persistent form of AFib. And the best way to go about doing it is catheter ablation. So these are the different stages that they talked about. Stage 1 is someone who is at risk for AFib, as I mentioned before, someone who has hypertension, diabetes, obstructive sleep apnea, smoking, alcoholism. Those are the patients that we need to keep an eye on. Pre-AFib is anything that you see on echo, whether it's left atrial dilatation, cardiomyopathy, MIs. In terms of EKGs, if someone has PACs, atrial flutter, atrial tag, those are at stage 2. And stage 3 is the one that we often know of with paroxysmal, persistent, long-standing, and then someone who has successfully AFib ablation, it's a 3D stage. And stage 4 is your where you make no attempts for rhythm control, and it's the one that we talk about. We call it permanent AFib. Before I end my talk, I have 3 questions. So I'm just going to read out the question, and if no one is willing to answer, I'll answer it, but I would prefer someone to answer it. So 54-year-old man presents with shock, blood pressure is 75 to 50. Walked under and found to have atrial fibrillation at 120 beats. What's the next step? Your options are A, emergent cardioversion, B, workup for precipitant cause and fluids, C, emergent cardioversion, workup for precipitant cause for fluids, precipitant cause and fluids, if not fluid over. So we can guess which one.
C.
C. All right. Why do you want to cardiovert this patient?
He's hemodynamically unstable. He's not perfusing his brain.
Okay.
Seemingly. So he is someone who needs to be cardioverted.
Okay. Do you think the AFib is contributing to his hemodynamic instability?
Because generally the rate is usually at higher rates, it contributes above 160s when you think.
Exactly. So the rate is pretty 120 beats per minute. It's not that high to contribute for someone who has a blood pressure of 75 by 50. And that is one point. The other point is, have we treated what is causing his hemodynamic instability? We don't know yet. So what's the point of cardioverting him? So first thing is, we'll see how he does with IV fluids. If he responds to it, so be it. If he does not, then we have to start thinking about what's going on exactly out there. So you have to work up the precipitant cause and give fluids. So yeah, you can use cardioversion in this patient. All right. Next question, 54-year-old man known to have heart failure with EF of 25%, presence of decompensated heart failure. He's found to have AFib at rate of 125 beats per minute, which is newly diagnosed. How should we manage this patient? A, emergent cardioversion. B, aggressive rate control to 80 beats per minute with cardism. Lenient rate control to 110 beats per minute with metoprolol, or diuresis.
Diuresis or maybe lenient rate control. I don't think giving cardism with the low EF is a good idea. I don't think he needs to be cardioverted, so I would probably diuresis. And then if we had to rate control, hold off the beta blocker, but if we had to, then lenient.
Yeah, so it's diuresis. So the most important thing is they are in decompensated heart failure. So cardism and metoprolol are out. They are in decompensated heart failure. You don't want to. Now about emergent cardioversion. As I mentioned before, we are in decompensated heart failure. So even if you do cardioversion in these patients, going to bring back them in sinus rhythm, but they are still having elevated LV pressures. So even if you get that atrial kick, it's not going to help them much. So the first thing you have to do is diurese them to see, how they respond. It'll help with their decompensation, and at the same time, it'll help with their heart rate also. So in this case, what I'm trying to go through these cases is first treat the cause and then think about rate control and rhythm control afterwards. Because most of the time they have something or the other happening with them before we even try to rate or rhythm control them. All right, this is a say a dirty question, but it's an important question. I think so. So 69-year-old man is diagnosed with frequent recurrences of symptomatic paroxysmal AFib. He has hypertension, diabetes, drinks alcohol daily. He has history of CAD, underwent stent placement 3 years previously. He has CKD, echo shows normal EF, left atrial enlargement, mild LVH. He has history of bleeding peptic ulcer 2 months ago. Required transfusion. His baseline heart rate is 72 beats per minute. Diltiazem did not relieve his symptoms. Baseline heart rate is now 58 beats per minute. Should he receive anticoagulation? He's already on aspirin, 81 milligrams CAD. So his Haspelet score is 5, which is elevated, which is at a high risk for bleeding. Should he not be started on anticoagulation? His CHA2DS2 is 4, which is again high. Should anticoagulation be started despite bleeding risk? Should you use dual antiplatelet instead of anticoagulation to mitigate bleeding risk? Or should we send him to cardiology for LA appendage closure? So he's got high bleeding risk, high thromboembolic risk. So I think he should be. So I think everyone knows that C is the wrong answer because no one uses dual antiplatelets anymore for stroke prevention. So the only question is, what do you do? Do you send them for disclosure device, or you say no anticoagulation, or you don't care, you just give anticoagulate? There are two possible answers in this. Not all three answers could be right. So the right answer is B. You would still anticoagulate them. As I mentioned before, even if the Haspelet score is high, Haspelet score only tells you what the bleeding risk is. You have to look into things that, can you decrease that bleeding risk? You have to, see what is their blood pressure, what is their kidney functions doing. Is there something that you can reverse? I know he has a bleeding peptic ulcer. Is there something that the GI doctors can treat it? There is a difference between someone having a peptic ulcer and someone having, for example, angiodysplasia on their EGD. That's something that you don't know what's happening. Or someone having diverticular bleeds where you can't treat them. So you have to figure out what is their bleeding risk. Is this bleeding risk reversible? If it is reversible, then you can start anticoagulation, because person with high CHA2DS2, high Haspelet risk score benefit still from anticoagulation just based on the net clinical benefit. So the answer is in this B. You won't be wrong to consider left atrial appendage closure device, but you have to first see and whether he bleeds or whether he can tolerate anticoagulation before we think about left atrial appendage.
Well, I'd add on though, with the new ACCHA guidelines, they would say that patient should stop aspirin as well.
Yep.
And so that's something as pharmacists, we are regularly asking about in that type of situation.
Yes, so that's the actually
I
because
don't
he
think
has
we have a
CAD.
recommendation in there, but
Yeah.
it's in there.
So yes, that is correct. So if someone has coronary artery disease and they are on aspirin and they have AFib and their CHA2DS2 is high, you can stop the aspirin. You can just continue with them on anticoagulation, because there is increased bleeding risk with having aspirin and the DOAC. And you have non-inferior benefit in terms of ischemic events when you just have just the DOAC.
Of course, there's some gray area if you have a really complex lesion that
Yes.
or something, but
Yeah. So
if they're stable, it should be considered.
it should be considered. Yeah. So if someone has complex PCF, they have a left main disease that has been stented, or they have history of in-stent thrombosis, then probably you would think about aspirin and DOAC, but you have to again go through the risk and benefit of bleeding and ischemic risk in those patients. Okay. Any other questions, you guys? No, I didn't cover a lot of things related to AFib. But if you have to take anything from this talk, I would say this is the most important thing, is risk factor management. We often talk about medication and all, but if we try to do the simplest things better, we need mitigate the risk of patients having AFib. So, right. And second, I'm ready to take any questions.
What do you see happening in the future with AFib?
I think it's going to be doctors are going to treat it more aggressively. Yeah, in terms of atrial fibrillation, especially the control part of it. People are going out to different medications and that's the reason why we have the guidelines have changed from 2A, where you could possibly consider to now like a class 1 indication, to consider catheter ablation as a first rhythm control strategy for patients who have symptomatic AFib. So the whole point being is we want to capture these patients as soon as possible and isolate their triggers and prevent them from going from paroxysmal to persistent form of AFib. So that will be another way of mitigating the risk of AFib.
Quick question. Can you discuss success of catheter ablation correlated with risk factors that you're dealing with? Because that's always a big question.
Yes.
If you're looking at 1, 2, or several catheter ablations.
Yes, that's a very good question. So when they mention out here in this point, on the second last point on the green slide for early rhythm control, when they say reduce LV function, there is a difference between a patient who is, for example, 50 years old, he had newly diagnosed AFib, and he has new low ejection fraction than a patient who is 75 years old. He has low ejection fraction for years, and now we diagnose them with AFib. You look at their echocardiogram, the left atrium is dilated, they have COPD and everything. They have obstructive sleep apnea, while the younger patient doesn't have, probably just hypertension, in this AFib. So the success of ablation kind of depends on what kind of patients you're choosing. The younger patient obviously has higher success of ablation, and the max success rate for ablation, single ablation would be about 60 to 70%. For the older patient, we wouldn't take them for ablation because there is very low risk of him maintaining sinus rhythm down the line. Even if I ablate him, he won't benefit much from it. The other point that I wanted to make was regarding ablation was the reason why people do redo ablation is because most of these ablations, when we say AFib ablation, it means pulmonic vein isolation. As I mentioned before in the pathophysiology, most of these are caused by premature atrial beats. Most of these premature atrial beats come from the pulmonic vein. That's why they are isolated during ablation. And once we ablate them the first time, there is a high chance of these reconnections forming between the pulmonic veins and the left atrium. That's why we have to do redo ablations for them. The chances of 2 ablations is higher. It's about maybe 70 to 80% if you choose the right patient. So it depends on what kind of patients are you looking into, and where you're ablating. Now there is another question about, because PACs could come from anywhere. It doesn't have to come from pulmonic veins. Do we find other triggers to ablate them or not? So far, studies haven't shown any conclusive evidence of other triggers, ablating other triggers, helping these patients. So it's sticking first to the pulmonic veins first so far, yeah.
Well, the follow-up question, do you recommend any monitoring for atrial fibrillation? Reveal devices, symptomatic, or whatever?
Yes, so yeah, that's the devices part. I didn't mention it out here because that's another huge topic. Yes, and there are different practices who do different things. So if you have someone in permanent AFib, for example, and you want to see what is their rate control, then you can do a device to see whether medications are working or not. You want to see whether they get bradycardic or not. If they don't already have a pacemaker, then you want to monitor that. Now, for example, if you have someone who is relatively, for example, someone has a stroke and you want to figure out what is the cause of the stroke, you have done all the stroke workup, you didn't find anything, and you label them as cryptogenic stroke, and then you can monitor them to see if there is any AFib. First, you start with 30-day event monitor. If that doesn't work, you need to put them on a loop record to see what's going on. Different conditions, you have different ways you can use devices here. Anything else? Or I didn't even cover choices or anticoagulation, but there are a lot of pharmacists out here.
I just, one thing that I've struggled with in practice a little bit lately is with CT surgery patients are seeing a lot more MACE procedures, which is basically surgical ablation plus, clippage of the left atrial appendage. And it gets really tricky to understand fully what the stroke versus bleeding risk, because a lot of these people are also then freshly post bypass surgery and what have you. And like, how aggressive should we be in the interim and more longer term? I don't know, it's just the guidelines are a little bit not very clear on what to do in some of these situations.
Yeah, it's not clear post. Yeah. With the left atrial appendage being clipped, you are kind of like, you don't have much options. So based on the current guidelines for AFib, if the surgeon clips the left atrial appendage or ligates it, that doesn't prevent them from being on anticoagulation. If their CHA2DS2 is high, you still need to continue them on anticoagulation. So that's the reason why it becomes an issue
And that maze probably stuns the myocardium a lot more. So,
So, yeah, so that can, predispose you to form thrombus, not in the left atrial appendage because that's gone, but, in the left atrium as such. So you still have to continue anticoagulation in those patients, unfortunately. And you can't use any of these left atrial.
and the question is, do you put them on heparin, in that high bleeding risk, and then that just gets really, really tricky when they still have chest tubes in. But anyway, I'm sure Lindsay has seen this a million times. So.
We do heparin on everybody.
Yeah.
So my question is, if you have like an AFib person that comes in, like me, for example, my Chad's 2-VAS is probably 1, a female. Do I need to be started on a heparin drip? Because I feel like we start everybody on heparin for new AFib, and I don't think everybody probably needs to be started on heparin drips right away if there's not another compelling indication.
So you came in with AFib, were you having symptoms?
No.
How did they find out? They just randomly find out that you're
Passed out at work.
so
What?
just okay, few hours you.
Yes.
The reason why I'm
My
asking,
troponins negative.
the reason why I'm asking this is because if you don't have any symptoms, then I don't know how long that AFib is on for. So, and if I don't know how long that AFib is on for, and yes, I'm going to start you on all the medications to control your rate. But at some point, I'll be like, you're young. You should not be in AFib. I can take you out of AFib if I were to think about cardioversion. So if I'm thinking about cardioversion, you would think about anticoagulation. But if I don't know how long you're in AFib, you're ultimately going to require PE to see if you don't have left atrial thrombus. Specifically, heparin as such, I don't know. I would, if you're younger, I would just think about anticoagulation, oral anticoagulation, because you're going to be on it. If I'm planning a cardioverting you down the line, so for 4 weeks, you're going to be on anticoagulation.
What if they self-cardiovert?
So I spoke about electric cardioversion. For self-cardioversion,
I feel like a lot of the cardiologists put them
yeah.
bridging after they self-cardiovert.
We just had one of those this week.
Yes, we have one.
I shouldn't speak on behalf of that. But yes, based on guidelines, yeah, you don't need to be. You don't need bridging. Bridging is another topic. Most of the time, you don't need to bridge. You either need to start or stop anticoagulation. Very rarely, only if they have mechanical valves or if their thromboembolic risk is more than 5% per year, then only you think about bridging. But otherwise, most of the time, you either start or stop.
Occasionally have a patient in the hospital that's going to have a real extended time without oral therapy too, that I think you can maybe argue for occasionally. But
And remember, dabigatran is generic now, so if they can't
Yeah,
afford a
that's good.
DOAC, dabigatran is generic now, so that could be an option.
I think you should be looking at a lot more dabigatran, and especially in younger patients.
It's
the
still
little
pretty
ladies get to
expensive.
be Issues. I just checked GoodRx yesterday. Pure cash prices, you can get it for usually $60 to $120.
Some of our
Really?
patients are, yeah.
So, and again, if they have Part D coverage, it should fall under a generic tier coverage at this point.
I've had a couple that are like 200
I think it's gone down though, so
when it first came out.
it was expensive when it came up.
Yeah, yeah.
It's teaching.
Unfortunately, we don't use dabigatran so much.
You should.
We should now. Price is reasonably low. compared to-
Little old ladies with marginal renal function, it's not a good choice, but a lot of younger, healthier people, it's a very good choice. It actually has the best stroke efficacy if you look critically at the